The next micro topic from the surgery of the left ventricular outflow tract obstruction is aortoventricular plasty cone operation. This approach was developed simultaneously in the late 1970s by Cone and Raston to treat tunnel type subaortic stenosis and hypoplasia of the aortic valve annulus. The position of the right coronary artery is accurately noted, and the longitudinal aortotomy incision is made down to the aortic annulus, while to the left of the right coronary artery toward the chamfer between the right and left coronary arteries. A transverse incision is made in the outflow tract in the right ventricle, just proximal to the pulmonary annulus. Now I will show you figure of 37.2. This is the here in the left one. Aortotomy has done, and also right ventriculotomy has done. Care must be taken to avoid damaging the pulmonary valve cusps, which lie near the point of entry of the incision into the right ventricle. Scissors are then positioned with one blade into the left ventricle through the aortotomy, and one in the right ventricle through the ventriculotomy, so as to join the incision between the right ventricle and the aorta. Opening the interventricular septum. This opening must be extended far enough below the tunnel stenosis, staying above the muscle of Lancisi to avoid the conduction system. The aortic valve is completely removed, and the valve sizer is then laid in the area of the divided annulus to estimate the amount of prosthetic patch required to enlarge the aortic orifice and to accommodate a predetermined valve size. An oblong shape Dacron or Gore-Tex patch is then trimmed and sutured to the ventricular septum by horizontal mattress sutures buttressed with a strip of Teflon felt on the right ventricular side of the septum. Now I will show you figures 37.33. Now the patch is sewn with pledged and Teflon stitches to the right ventricular outflow tract. And also this is the VCD. The suturing of the patch is interrupted just beyond the aortic annulus, and the appropriate size aortic valve prosthesis is then sutured in place in the standard manner with simple interrupted sutures of mattress sutures through the aortic annulus and the valve ring. Now we will show you the picture of 37.34. This is the picture, and now here we are doing the implantation of the aortic prosthetic aortic valve here, prosthetic aortic valve, and also the suturing of the VCD has done till the aortic annulus. The part of the valve covered by Dacron is attached with horizontal mattress sutures in the valve ring, which are then brought through the Dacron and tied on the right ventricular side of the patch. At this time, each of the two previously placed sutures at the aortic annulus are tied and then run onto the aorta so as to enlarge and close the aortotomy incision. Figure 35, we are going there, and in the left you have seen that the prosthetic valve has implanted, and you see here that in the patch there are sutures of the valve. This is the VCD and patch with sutured with patch, and then the aortotomy will suture with the patch, and we will read it now. After completion of the suture lines, routine devouring is done and the aortic clamp released. Any leakages in the patch can be repaired. The defect in the right ventricular outflow tract is then closed with a large patch of autologous or bovine pericardium, which is brought over the entire Dacron patch so that so that the prosthetic patch is totally within the right ventricular cavity. Any leakage though the Dacron patch will thus be into the right ventricle. This greatly reduces postoperative bleeding. Now in the 36, the aortic patch has completed. The pericardial patch in the right ventricle outflow tract will suture here, and this is the completion version of the Kona operation. Extended aortic root replacement with aortic homograph. As an alternative to the Kona operation, Clark applied the concept of aortic root replacement combined with the concept of aortoventriculoplasty to describe the extended aortic root replacement, which has the advantage of not using a prosthetic valve. The aortic and the cardiac incisions are similar to those used in aortoventriculoplasty, a vertical aortotomy, and an oblique incision across the right ventricular outflow tract. These two incisions come together at the aortic annulus between the left and right coronary ostia. In this area, the incision is carried across the aortic annulus and down into the infundibulum septum. The ascending aorta is transected and the coronary arteries are excised with a cuff of aortic wall and mobilized as for an aortic root replacement. Now you see the figure of 37.38. Here you see the incision of the VCD and right ventricular outflow tract, and also you see that the aorta and aortic valve has incised, and the homograph will be seen here, so we will read it. Aortic homographs of at least 80 mm internal diameter can be used even in early childhood. Excess muscle is trimmed from the proximal portion of the homograph. The anterior leaflet of the mitral valve is left attached. The homograph is then oriented so as to have the mitral valve covering the incision in the infundibular septum. The proximal anastomosis of the homograph to the posterior aspect of the outflow tract is then carried out with a running suture of 4-0 Prolen. Figure 38, we have seen it. This is interrupted and secured on either side of the aortotomy incision. The anterior leaflet of the mitral valve is then trimmed so as to fill exactly the septal incision, onto which the leaflet is sewn with several interrupted horizontal mattress sutures reinforced with Teflon pleats. Next, the coronary arteries are anastomosed into the two defects created in the homograph. The left coronary artery may be just opposite to the origin of the right coronary artery of the homograph, in which case this ostium is enlarged. A hole has to be made in the anterior aspect of the homograph for the right coronary artery. Care must be taken not to damage the aortic valve leaflet during that maneuver. Now you see the picture of 7.39. The coronary arteries are sewn in the patch. Are sewn in the aortic homograph. Next, the distal anastomosis of the homograph to the host's ascending aorta is carried out with a running suture of 4-0 Prolen. At this point, the aortic clamp is released, the left side of the heart is deaerated, and the patient is rewarmed while the incision of the right ventricular outflow tract is closed. This is done with a triangular patch of pericardium or with a piece of aortic homograph. The patch is secured to the margin of the right ventriculotomy incision and along the annulus of the aortic valve of the homograph. Particular care is taken to anchor the patch securely at the junction of the right ventricle and the homograph. Combined Ross modified Kona procedure. This is our preferred option for infants, children with aortic valve disease complicated by complex VOTO. And this topic we will discuss in the next part. Thank you very much. Thank you very much for listening and being with us.